Hello, everyone. I'm Jennifer Green, a professor of medicine in the Division of Endocrinology at the Duke University School of Medicine. I'm joined today by Dr. Amreen Dhanani, who is an associate professor of medicine in the Division of Gastroenterology and Hepatology, also at the Duke University School of Medicine. We're excited today to talk about the intersection of MASH and cardiometabolic risk. We'll go through patient cases and discuss both screening, diagnosis, and management of this condition. Our first case will allow us to apply advances in the diagnosis and management of this condition to tackle the burgeoning MASH epidemic. Our objectives for the case are to help us identify populations at high risk for MASLD, to discuss non-invasive tools to risk stratify patients at risk for significant liver fibrosis due to MASLD, and also to apply current therapies to treat MASLD, although that will be covered in greater detail in the other section. Our case is a 37-year-old man with class 3 obesity and a BMI of 40 kilograms per meter squared and obstructive sleep apnea, who is referred to liver clinic for workup of the incidental finding of hepatic steatosis on ultrasound. Review of his medical history excludes significant alcohol use, any important relevant medications or over-the-counter or herbal supplements. He has negative viral serologies. He also has a normal autoimmune workup, ceruloplasmin level, and alpha-1 antitrypsin level. He has no family history of cirrhosis or liver cancer. Provided are some laboratory data, including an albumin level, which is 5, ALK-Phos 112, ALT 31, AST is 40, total bilirubin 0.6, and the platelet count is 164,000. So our first question is whether or not this individual is at risk for MASLD. And to clarify this abbreviation, that means metabolic dysfunction associated steatotic liver disease. So our options are, yes, he has hepatic steatosis on imaging. Yes, he has 2 metabolic risk factors for this condition. No, because he has normal liver enzymes. Or no, he's too young to have a diagnosis of MASLD. So Dr. Dhanani, I'm going to invite you to talk a bit about this patient's case and what we should be thinking about when we see individuals like him.
Thank you so much, Dr. Green. So I'd like to start off by introducing MASLD, which, as Dr. Green mentioned, stands for Metabolic Dysfunction Associated Steatotic Liver Disease. This is new nomenclature. Prior to this disease was referred to as NAFLD, or non-alcoholic fatty liver disease. And really the nomenclature was changed last year in June of 2023. What's new about this nomenclature is there was a society of multiple different subspecialties, stakeholders, patient advocacy groups that got together to try make some recommendations about this disease and the nomenclature to make it less stigmatizing. And also one of the other feedback about the nomenclature has been, so it's not a disease of exclusion, but how can we make the disease state a little bit more inclusive? So the new nomenclature, now the overarching term is something called, we describe it as steatotic liver disease. And this by definition is having the presence of hepatic steatosis. And this can be identified by imaging or biopsy. And then the next step you want to kind of answer is, does this person have metabolic risk factors? And here on the left of the screen, you see the multiple cardiometabolic risk factors that make up metabolic syndrome. if you have the presence of metabolic risk factors in the presence of steatotic liver disease, so the presence of steatosis, by definition, that would be someone you would describe as having MASLD. What's really new and novel about this new nomenclature is that we have now this overarching term called steatotic liver disease, which includes all spectrums of fat in the liver. So as you can see here on the left, again, you have other causes of hepatic steatosis, such as other etiologies, such as alcohol, drug-induced liver injury. You have to think about certain medications as well that can give you fat in the liver. But in addition to that, we have a new category called MASLD, and this is a category that doesn't exclude alcohol completely like we did in our previous nomenclature, but this recognizes the fact that NAFLD or MASLD can have alcohol associated with it as well as a modifiable risk factor. So this would be now a new category called MASLD. And again, to reiterate, MASLD now is an inclusionary diagnosis versus an exclusionary diagnosis, which is what our previous nomenclature had.
I think that's really important, and I'm glad that you highlighted the potential for overlap. As someone who is not a hepatologist, it's been difficult in the past for me to determine whether or not someone has had enough alcohol exposure to call his liver disease alcohol related rather than that related to metabolic dysfunction. It's nice to know now that there's a category that is inclusive of all the potential contributors to their liver disease.
I agree. So once you've identified someone to have MASLD, it's really important still to define how much fibrosis or scarring they have in the liver. And here what I'm showing you are the histological stages of fibrosis or liver scarring. On the left of the screen, you see stage 1 fibrosis, which is defined by fibrosis in the sinusoids. And this is here illustrated by the blue-purple stain that you see. And as you go across the slides, you see that these fibrous bands become more extensive, they become thicker, they connect one area of the liver to another area, which is what we describe as bridging fibrosis, which would be equivalent to stage 3 fibrosis. And then when you have large nodules that form with fibrous tissue around them, we define that as cirrhosis. And this is the classification that is used by the NASH-CRN to stage fibrosis. The reason we care about fibrosis is because fibrosis has been associated with not just liver-related mortality, but also all-cause mortality. Here, what I'm illustrating to you are results from some of our first studies that were interested in looking at the association of fibrosis stage to liver-related outcomes. And you can see here that as quickly as stage 2 fibrosis, or what we now describe as moderate fibrosis, there is a 10-fold increased risk of liver-related mortality and up to a 17-fold increase in liver-related mortality in those with advanced fibrosis. We also know that to go from one stage of fibrosis to another stage of fibrosis can typically take anywhere between 7 to 14 years, depending on whether or not you have the inflammatory features of this disease, which is steatohepatitis. But we also now have data to support that 1 in 5 or 22% of patients who already have stage 3 or advanced fibrosis will progress to cirrhosis in as quickly as 2 years. So in general, we say it takes about 7 years to go from one stage of fibrosis to another stage of fibrosis, but there is still a population, about a fifth of the population, who will accelerate to cirrhosis much faster. We have moved our needle from thinking about fibrosis from advanced fibrosis, which is histologically defined as stage 3 fibrosis, to moving the needle backwards now, where we start really worrying about liver-related mortality and definitely all-cause mortality in people who have moderate fibrosis, or what we now define or describe as F2 fibrosis. In the non-cirrhotic population, so people who do not have cirrhosis, the leading causes of mortality are cardiovascular disease first, before they run into liver-related complications, and we will be covering those in the next few slides as well.
Well, let's get back to our case. Again, we had asked whether or not the individual that we presented earlier was at risk for MASLD. We have a couple of different reasons why the answer might be yes, either that he has hepatic steatosis on imaging, or that he has 2 metabolic risk factors for the condition, or no, because he has normal liver enzymes, or no, because he's too young to have MASLD. What's the correct answer? Well, the correct answer is yes, because he has 2 metabolic risk factors. Dr. Dhanani, do you want to elaborate on that a little bit?
Yeah, sure, absolutely. So I want to go over why answer 1 is incorrect. So as per the new definition, the presence of hepatic steatosis on imaging does not mean somebody has MASLD. It means that somebody has steatotic liver disease, which is that overarching terminology that we're using to define anyone who has fat in the liver. Here we said he had class 3 obesity with a BMI of 40, so he has obesity with a associated comorbidity such as sleep apnea. He did not have any other causes of steatotic liver disease, so we had done a very thorough job at making sure he had no competing etiologies of steatosis in the liver. So we'd ruled out alpha-1 antitrypsin deficiency, Wilson's disease, autoimmune diseases. We had taken a detailed history of their medications, herbal supplements, and over-the-counter medications. And we had also taken a detailed history of alcohol, making alcohol-associated liver disease not on the differential, but also MetALD is not on the differential because he did not drink any alcohol. So based on that, he has MASLD based on the fact that he has 2 metabolic risk factors.
So how big a problem is MASLD?
That's a great question. I'd like to go into some of the data that we have in terms of the prevalence of this disease. But to start off with, MASLD or NAFLD is now defined and definitely recognized that it is a metabolic disease. It shares common risk factors with cardiovascular disease, particularly obesity and insulin resistance, or the presence of type 2 diabetes or prediabetes. And it does carry a 2-fold greater risk of instant diabetes and higher risk of chronic kidney disease. It leads to increased mortality and morbidity, as I said earlier, from a cardiovascular disease standpoint, and with more advanced fibrosis, we definitely run into problems with liver-related complications. So when we look at the epidemiology data on the prevalence of this disease, we think it's about 35 to 40% of the global population, or and similar numbers for the United States. I'm actually going to say that that's probably an underestimate, because most of our data that's accumulated is based on either imaging technology or abnormal liver enzymes. So I do believe that the prevalence of this disease is most likely higher than that has been reported. You can see the highest rates of MASLD or NAFLD are in Latin America, and we think this is probably related to some genetic predisposition to this disease. Very high rates in the Middle East and Southeast Asia, and with the lowest prevalence rates in North America or Western Europe. What I would like to highlight to you is that diabetes in itself is a high-risk population for MASLD. So here what I'm showing you is results from a systematic review and meta-analysis looking at the global prevalence of MASLD amongst type 2 diabetics. So as you recall, the global prevalence is about 35 to 40%. But when you look at the data in type 2 diabetics specifically, the prevalence is as high as 55%. And even worse, or even more strikingly, the rates of advanced fibrosis are even higher than the general population. So some things to keep in mind when we think about our type 2 diabetic population, that these patients are at increased risk of both NAFLD, steatohepatitis, advanced fibrosis, and hepatocellular carcinoma. At least 50% of diabetics have some spectrum of this disease. These patients are at risk of both cardiovascular disease, both morbidity and mortality, and as we know, contribute significantly to healthcare costs and economic burden. What I'd like to highlight through these results is that advanced fibrosis is very common in diabetics. So these are results from a study that was conducted in primary care where 561 patients with type 2 diabetes were screened with FibroScan or vibration-controlled transient elastography. And fibrosis, significant fibrosis was defined as a liver stiffness measurement of 8 kilopascals and higher, and hepatic steatosis was defined as a CAP score of 274 or higher. And you can see here that while as expected, the prevalence of steatosis is 70%, but the prevalence of fibrosis is high in this patient population. You can also see when we look at the different stages of fibrosis, we have a lot more patients sitting with moderate to severe fibrosis, moderate to advanced fibrosis in this particular population. What I really liked about this study was it highlighted a common scenario that comes up in practice and in primary care. And the results here on the right illustrate that when we look at an ALT or an AST cutoff of 40, which is commonly regarded as a normal liver enzyme value, there were only 6% of patients that fell into this category of having hepatic steatosis based on the AST, and only 10% based on the ALT. If we drop the upper limit of normal value to 30, you see that 13% of patients had a prevalence of hepatic steatosis, and 22% of patients had the prevalence of hepatic steatosis based on those liver enzymes. Of note, the mean ALT and AST in this patient population of 561 patients was actually normal, with an AST mean of 21 and an ALT mean of 24. So what I want to illustrate here is that elevated liver enzyme, you do not need to have elevated liver enzymes to be at risk for MASLD in a type 2 diabetic patient. You should guide your assessment of MASLD just based on the fact that a person has type 2 diabetes. The presence of diabetes increases the risk of liver cancer, and this is very nicely illustrated in this study that was conducted in the VA healthcare system. And you can see here that when patients with diabetes are compared to patients with not having diabetes, and when they are followed longitudinally, the cumulative risk of NAFLD or MASLD in the veterans was higher in those who had type 2 diabetes. In addition, the rates of hepatocellular carcinoma was also higher in the VA population who had type 2 diabetes. So in general, we think about type 2 diabetes being an independent risk factor for liver cancer, and it is associated with a 2 to 3-fold increased risk of both developing MASLD or NAFLD, and hepatocellular carcinoma. And lastly, what I want to illustrate here is that hepatic steatosis, the presence of hepatic steatosis is associated with MACE, and these are results from a study where the median follow-up was 25 months, and the overall rate of MACE was 3.1%. Baseline steatosis was associated with significantly higher rates of MACE compared to those who did not have steatosis. And even after you adjusted for plaque or the presence of plaque or stenosis, this association was present just based on the fact that somebody had hepatic steatosis.
So why don't we talk a little bit more about MASH screening and diagnosis?
So the first question, the first thing that we want to highlight is who should be screened for advanced fibrosis. So we have guidelines from 2017 that used to say that patients with elevated liver enzymes, so again, an elevated liver enzyme in general should be an ALT or an AST of greater than 30, not greater than 40, or what is defined by your lab. Presence of hepatic steatosis in imaging and patients who have type 2 diabetes. These guidelines were updated to now include all patients with type 2 diabetes should be assessed for MASLD-associated fibrosis, patients who have medically complicated obesity, MASLD or NAFLD in the context of moderate alcohol use, and because of they may be a genetic association of this disease, first-degree relatives of a patient with cirrhosis due to MASLD or NAFLD. And this is actually something that is endorsed and supported by multiple society guidelines, not just in our primary care setting or our diabetes association, but also supported by several liver guidelines, hepatology guidelines, not just in North America, but also globally. Biggest risk factors for MASLD are morbid obesity and type 2 diabetes. But here, what I want to highlight is that there are multiple other risk factors, specifically metabolic risk factors, that have been shown to be independently be associated to having MASLD, and some being associated to fibrosis as well. So things like dyslipidemia, people with polycystic ovarian syndrome, obstructive sleep apnea, other endocrinopathies like I highlight here. And then what I'm highlighting at the very bottom are the 2 genetic associations that have been seen with this patient population.
So our next question is, which of the following tests can be used to assess the risk of fibrosis in our patient? We have the options listed of liver biopsy, FibroSure, FIB4, and ultrasound of the abdomen.
Thank you, Dr. Green. So here I'm going to, over the next few slides, I'm going to review some of the society guidelines that we have that give us some guidance or an algorithm as to how we should be assessing our patients for MASLD-associated fibrosis. So here, just highlighting some of the guidelines that are out there that have very simple algorithms that you can follow to risk stratify your patients appropriately for MASLD and fibrosis. And again, this is endorsed by the American Heart Association and as well as the American Diabetes Association. So I'm going to walk you through the algorithm. So the primary assessment that should be performed in any patient who you are suspecting has MASLD should be a FIB4. So FIB4 should be performed in patients with medically complicated obesity, again, patients with MASLD in the context of moderate alcohol use, a first-degree relative of patients with cirrhosis due to MASLD or MASH, and those with type 2 diabetes. The FIB4, which we will go into in a little bit more detail over the next few slides. But here I just want to give you the cutoffs that you should be thinking about. So anyone who does not have a FIB-4 of 1.3 and higher, those patients do not have advanced fibrosis. Those patients can probably be managed by their primary care or their endocrinologists. And really important to know that these patients do require serial fibrosis assessment every 1 to 2 years if you're pre-diabetic or type 2 diabetic or have metabolic risk factors, or every 2 to 3 years if you do not have diabetes and do not have any metabolic risk factors. The patients that require some form of secondary assessment are patients who have a FIB-4 of 1.3 and higher. And secondary assessment can happen different ways. They are blood-based tests and there are imaging-based tests that can be used. So the vibration control transient elastography, which is commonly referred to as a FibroScan, can be used as a secondary assessment. And then you have a serological-based test called the ELF test, which is the Enhanced Liver Fibrosis Test, which can also be used. Again, these are cutoff values that should help guide you as to whether or not these patients require accelerated care through subspecialty care with hepatology, or can they safely be followed in the primary care setting. So the people that need to be referred to hepatology are those that have an intermediate score. So that is a FibroScan result of 8 and higher, up to 12, or an ELF score of 7.7 to 9.8. And the ones that you're definitely worried about being at risk for cirrhosis are those who have a high FibroScan reading of 12 kilopascals and higher, or an ELF score of 9.8 and higher. Other patients that you want to automatically refer to hepatology are those who have a FIB-4 greater than 2.67 and higher. That score is a cutoff that has been shown to be associated with having cirrhosis or advanced fibrosis. Once it comes to hepatology care, really the goal is to identify and manage patients at risk for MASH or NASH or cirrhosis, and then conduct any other additional testing that will help further risk stratify patients. Again, if your further testing categorizes these patients into low risk, they can be followed by primary care and reassessed periodically. And of course, if they are at high risk, they should stay in hepatology care for further workup, testing, and appropriate hepatocellular carcinoma surveillance. So what is a FIB-4? So FIB-4 is a computation of common blood tests that are obtained routinely in a lot of our patients. It uses age, it uses an ALT, AST, and platelets to come up with a score. And as I alluded to earlier, a low FIB score of less than 1.3 very confidently will exclude advanced fibrosis. And those with a score of 2.6 and higher are very likely to have advanced fibrosis or cirrhosis, thus requiring further workup. The category that requires secondary assessment, again, are those who have a score of 1.3, between 1.3 and 2.67. Those are patients that require secondary assessment. And this population can account for about 40 to 50% of the people we will be assessing for fibrosis. We know that FIB-4 is not just a good initial screening tool, but it has also been shown to be an independent predictor of mortality and liver-related outcomes. And so this is actually a large database that look to see associations of developing MASH or NASH or MASLD or NAFLD, and if there was an association with the different FIB-4 cutoffs. And as you can see here, across all graphs, that the higher the rate of fibrosis defined by a FIB-4 score was associated with having the presence of steatohepatitis, MASLD or NAFLD, and also associated with an increased risk of liver-related mortality. Switching gears to some of our secondary testing, so the ELF test, which is the Enhanced Liver Fibrosis Score. This measures 3 direct markers of fibrosis, the hyaluronic acid, procollagen 3 amino terminal peptide, and tissue inhibitor of matrix metalloproteinase 1. We have data to support that it is performs well in detecting advanced fibrosis, can be utilized as a prognostication tool, and also can be used to follow disease and disease progression, and overall has performed better than other non-invasive tests for prognostication. And here, what I have at the bottom here are the different cutoff points that have been proposed to define different stages of fibrosis. This test has been approved, FDA approved in 2022, and is available through LabCorp and Quest. Again, ELF is predictive of progression than a liver biopsy. And here what I'm showing you are some results that were extrapolated from a clinical trial that was being performed in the MASH or NASH space. And what we are showing you here is that an ELF score of 9.76 and higher was associated or a predictor of progression to cirrhosis. So what your baseline ELF was, and also the greater the change in the ELF, were associated with increased risk of progression. And again, the cutoff or the cutoff that was found was 9.8 and higher to be predictive of advanced fibrosis. Switching to some of our imaging technology that can be used to identify steatosis and fibrosis. So this is an image of what a FibroScan looks like. So again, a FibroScan is able to give us two types of information: how stiff is your liver, which correlates to the amount or the degree of liver fibrosis, and a CAP score, which allows us to know how much fat is in the liver. And this can be done in real time, takes a few minutes, and also provides almost a point of care testing for a lot of our patients. A cutoff value of 8 kilopascals and higher has been shown to be consistent with significant fibrosis, which is F2 fibrosis. And just understand that there will be some false positives, especially in those who've eaten recently. So we do recommend that patients come in 3-4 hours fasting for these procedures. And there are some inaccuracies or failures with this technology, and we typically find these in people who have central adiposity. The presence of ascites can give you an inaccurate score, and also there are guidelines in terms of who is proficient enough to perform these tests. And lastly, to just go over one of the imaging technologies that we have available to us it's MRI-based, and this is MRI-based technology that allows us to assess both steatosis and fibrosis, and this is called the MR elastography. And then we also have the MRI PDFF, which allows us to define the percentage fat as a percentage. The cutoffs for MR elastography are a little bit different from the cutoffs that we use for FibroScan. So here, a cutoff of 3.63 kilopascals is consistent with F3 fibrosis or advanced fibrosis and higher.
Okay, thank you so much for that very comprehensive review of potential next steps. So let's revisit our question. So for our particular patient, which of the following tests could be used to assess his risk of hepatic fibrosis? And again, the options are liver biopsy, FibroSure, calculation of the FIB4, or ultrasound of the abdomen. So let's highlight the correct option. Yes, so I think you've really driven that point home that we should be starting with the FIB4. It's an easy calculation to do. I would point out that in the institutions where I work, if you order a GI panel, and oftentimes they will calculate the FIB4 for you automatically, so it almost requires no work. We have another question. This one is really focused on patients who might benefit from or who have indications for further evaluation by a hepatologist. And the patients whom we should consider for hepatology referral include, first, a 37-year-old man with a FIB-4 of 1.9 and an LSM of less than 7 kilopascals. Second, these are all 37-year-old men, so we can skip that for each of the options, but this individual has a FIB-4 of 1.9 and an ELF of less than 7. The third option is the same 37-year-old man with a FIB-4 of 0.86 and an LSM of less than 7. Or finally, a 37-year-old man with a FIB-4 of 1.9 and an LSM of greater than 12. Which of these individuals would benefit from a hepatology evaluation? Why don't we highlight the correct answer? Yeah, so it's the fourth option, and I believe that would be based on the LSM of greater than 12. So Dr. Janani, why don't you go through some of the key takeaway points that our listeners should take forward with them and apply in their clinical practice?
Great, thank you. So really start getting used to the new nomenclature. The MASLD is the new NAFLD. I hope I have highlighted that all type 2 diabetics should be screened for MASLD. And the way to do that is with a simple test called the FIB-4, which should be used as a primary assessment for liver fibrosis assessment.
Well, thank you so much for educating us about, again, this new nomenclature, patients who are at risk for the condition, and how we can best initiate their medical evaluation. Thanks to everyone for joining us for this module.
Thank you.